So hello and welcome to today's complimentary webcast presented by the American Association of Cardiovascular and Pulmonary Rehabilitation. Today's presentation is titled, The Bundles Are Coming, a primer for cardiac rehab professionals. My name is Hannah Meerhoff and I'm on the education team for AACVPR, and I will be serving as today's moderator. The Centers for Medicare and Medicaid Services, or CMS, have recognized the benefits of cardiac rehabilitation, and in 2017 will introduce pilot programs that will provide cardiac rehab incentive payment models for AMI and CABG, and will also provide a cardiovascular bundle payment system. As an organization of professionals delivering those services, AACVPR is continuing to consider the best way to help professionals prepare for a more efficient and evidence-based plan of care. To meet these new challenges in reimbursement and delivery of service, AACVPR launched an initiative called Roadmap to Reform, or R2R. This presentation is the first in a series of learning opportunities from AACVPR to help healthcare professionals navigate these reimbursement changes. I'm excited to introduce our first presenter today, Tracy Herwig. Tracy is a cardiac and pulmonary rehab coordinator at Mercy Medical Center, part of Ascension in Oshkosh, Wisconsin. She is a registered clinical exercise physiologist and has worked in the field of cardiac and pulmonary rehab for a number of years. She is a fellow of AACVPR and currently serves on the AACVPR Board of Directors as the Healthcare Reform Committee Liaison. She is also the current editor for News and Views. Our second presenter today will be Kate Trainer. Kate is the Director of Cardiovascular Disease Prevention Centers at the Massachusetts General Hospital Heart Center. She is a member of the Massachusetts Association of CDNPR. She is a fellow of the AACVPR and currently serves on the board and is a candidate for secretary of the organization. Kate has 31 years of experience in cardiac rehab and is proud to participate in this session today to share her expertise with all of you. At this time, I'm excited to turn the presentation over to Tracy.
Welcome, everyone. At last count, over 600 people had registered for this webinar. Thank you very much for taking time out of your busy day. Kate and I hope that we will be able to provide you with the information and motivation to help you navigate your way through this exciting time. This is a call to action. The cardiology episode payment model or bundled payment model implementation date is right around the corner. It's imperative that we prepare now. Throughout the course of this presentation, you may hear the terms episode payment model and bundled payment model used interchangeably. It seems like everything is changing all the time in healthcare, but there is a change coming the likes of which we have never seen in cardiac rehab. AACVPR has created a new initiative, R2R, or Roadmap to Reform, to help all of us navigate through the proposed changes in healthcare and specifically those affecting cardiac rehab. Our purpose today, we will provide you with the whys of healthcare reform, an overview of the CMS cardiology bundled payment model as well as how it affects cardiac rehab, the benefits to you and your patients, and strategies for all of us to prepare and to be ready to go on the go-live date of July 1st, 2017. We have all seen this slide or something very similar. The bottom line, the United States is not leading healthcare in quality despite leading in costs per dollar spent. The prevalence of chronic disease in the United States, again, is a very familiar concept to all of us. The prevalence of all chronic disease, including cardiovascular disease, in the United States continues to rise rapidly, with no indication of slowing down in the foreseeable future. It's estimated that the cost of MIs and CVAs account for 1 out of 3 deaths and result in over $300 billion in healthcare costs annually. But let's take a look at this slide, which outlines the direct as well as the indirect costs. Indirect costs, those are things such as rent, heat, lights, etc. Those costs continue to rise, but at a very gradual rate. In contrast to this are the direct costs, those associated with personnel, supplies, and equipment. Their rate of increase is astronomically greater. What are the economic and social determinants of healthcare in the United States? We know there's an aging population, and with this aging population comes an increased demand for both acute and post-acute care services. Hospital readmission rates are being targeted for quality measures and efficiencies. The growth of post-acute care spending is a focus for government intervention, concern, and control. And we know the three most common readmission diagnoses are heart failure, COPD, and pneumonia. But this slide outlines the continuum of payment models that we face. In the past, and maybe for many of us, we're still engrossed in the fee-for-service model. Volumes first, quality second, sometimes a distant second. But for the past few years, we've been hearing more about value-based payments, episode payment based on quality, looking at overall quality and process improvement. And the future is that of care coordination, the whole system working together in a coordinated fashion to improved patient outcomes. Sounds like the proposed episode payment model to me. So what is this episode payment model or bundled payment model? It is a structured payment around the total patient experience of care, all services start to finish, bundled in one payment for a single episode of care to increase quality of care and decrease cost. The focus is on the value, outcomes per dollar spent. Medicare's goal is that 50% of traditional Medicare payments will flow through some form of alternative payment model by 2018. Now, the current episode payment model that is being proposed for cardiology and cardiac rehab centers on the date of hospital admission through 90 days post-hospital discharge. But CMS is considering a long-range episode payment model for 12 months. There's a white paper posted on the AACVPR Legislative and Regulatory Action page that addresses this in greater detail. On July 25, 2016, the Department of Health and Human Services announced the launch of new payment models for healthcare delivery and payment, a shift from quantity to quality with incentives for hospitals to deliver better care for less money. July 1st, 2017 is the big day. The bundled payments for acute MI and CABG patients go live. Again, this focuses on the date of hospital admission through 90 days post-discharge. It addresses fee-for-service Medicare patients only. It excludes Medicare Advantage plans. 98 yet-to-be-announced MSAs or metropolitan statistical areas will be involved in this episode payment model. Now, please keep in mind that these MSAs or metropolitan statistical areas, each is a geographical area which may include more than one and possibly several individual hospitals. Karen Louie will host a webinar on December 15th, shortly after the MSAs are announced, and will provide more detailed information. So what can we learn from those programs that have been involved in other episode payment models? Well, the Healthcare Finance Management Association surveyed a number of facilities involved in the cancer and joint replacement bundles, and this is what they found. 69% said the bundled payments have enhanced their quality. 63% said the bundled payments are helping them contain costs by simplifying administration. 50% said the bundled payments are reducing overall healthcare costs. And 49% said the bundled payments are contributing to improved health outcomes. But this is an example of one healthcare system who's implemented a bundled payment model for cardiovascular disease. And their results? A decline in readmissions, reduced hospital charges, and even a shorter length of stay for CABG patients. So again, let's take a look at the proposed episode payment model for cardiology. It is one payment for all services provided from the date of hospital admission through 90 days post-discharge. There is an exciting incentive program in an attempt to increase referrals to and participation in cardiac rehab for patients with acute MI and CABG. This incentive, it's $25 per session for the first 11 sessions, and then $175 per session for sessions 12 through 36, in addition to the customary payment for cardiac rehab. Why the incentive? Because studies have shown that the longer a patient participates in cardiac rehab, that is, the greater number of sessions attended, as long as it's medically necessary, of course, the better the quality outcomes. 90 MSAs will be selected for the incentive program. 45 will be in the episode payment model, while 45 will not. This is an algorithm that Kate and Nicole Lewis from the National Office created to help us all understand the layout of the proposed episode payment model. Kate will explain each aspect of this in greater detail in just a few minutes, but let me give you an overview. 294 MSAs were selected to be included in the project. 98 MSAs will be in the episode payment model, while 196 will not. Of the 98 MSAs in the episode payment model, 45 will receive the incentive and 53 will not. Of the 196 MSAs not in the episode payment model, 45 will receive the incentive while 151 will not. Again, please remember each MSA may contain one, a few, or even several individual hospitals. This is a screenshot of the Regulatory and Legislative Information webpage under the Advocacy tab on the top of the AACVPR website. The link circled in red will take you directly to the Federal Register, pages 50817 through 50827, to find out the specific 94 MSAs that are eligible. You must be logged into the AACVPR website to access the information. Let's talk a little bit about payment. The target price established by CMS for each episode of care for MIs and CABG is based on both hospital-specific as well as regional data. Participant refers to a hospital, not to a specific person or patient. If a participating hospital provides quality care below the established target price, the hospital will be reimbursed by CMS. If the hospital provides care but exceeds the target price, the hospital must repay the difference to CMS. An exciting aspect of the cardiology episode payment model is that CMS recognizes the value of cardiac rehab. It improves long-term outcomes. This episode payment model project proposes to test the effects of quality of care and expenditures by providing incentive payments to encourage and promote care coordination. What are the goals of this payment model? Number one, to understand the effects of the incentive in an episode payment model, as well as the traditional fee-for-service setting. And number two, to examine the effects of each of the four groups on quality and efficiencies. Now, CMS will be monitoring this project, and it will assess hospital readmission rates, HCAHPS or patient satisfaction survey scores, mortality, the amount of care deferred beyond the 90 days post-hospital discharge or the end of the model, as well as cost effectiveness of these measures. Murray Lowe is a master of statistics as it relates to cardiac rehab. This is data that he has pulled together from various studies that outline the value of cardiac rehab. This is information that you should have at your fingertips as you speak with staff, physicians, and administrators. It addresses the value of cardiac rehab and the role of cardiac rehab in the episode payment model, as well as the future of cardiac rehab. Do you have similar information about your specific program? Well, what are the benefits to cardiac rehab professionals and to cardiac rehab programs? The proposed episode payment model will increase referrals to cardiac rehab programs. It will increase the awareness of cardiac rehab as well as the role of cardiac rehab and the role it can play in the proposed cardiology episode payment model. There are the financial rewards of the two-tiered incentive payments. Remember, the $25 for sessions 1 through 11 and $175 for sessions 12 through 36 are in addition to the customary reimbursement for cardiac rehab services. And it's an opportunity for program revision, an opportunity for all of us to take a step back, to look at our programs, and to look for innovative practice models. It might simply be tweaking your program slightly or doing a major overhaul focused on providing the highest quality care in the most cost-efficient and effective means possible. But let's get to what's really important. How do our patients benefit from this? This is what it's all about. How do we best take care of our patients? Well, there will be increased access to cardiac rehab programs, earlier enrollment in cardiac rehab programs. That means earlier assessment exercise guidelines, education, and counseling. Please remember that studies have shown that for every 1-day delay in starting cardiac rehab, there's approximately a 1% decrease in the likelihood of that patient enrolling in that program. The incentive payments may actually be used to offset payment for patients, such as transportation support. And coordination of care, all aspects of healthcare working together to provide effective and efficient care for improved patient outcomes at lower costs. So yes, cardiac rehab is the solution, and so is Roadmap to Reform, AACVPR's program to help all of us get from where we are currently to where we need to be to not only survive, but to thrive in the new environment of healthcare reform. Now, before I turn the presentation over to Kate, I'd like to introduce a topic to many of you. It's called Million Hearts. It is a national initiative co-sponsored by CMS as well as the Center for Disease Control, along with federal, state, and local sectors. Its goal is to prevent 1 million heart attacks and strokes by 2017. It has formed a partnership with AACVPR and over 30 professional organizations to create the Cardiac Rehab Collaborative. Its goal is 70% participation in cardiac rehab and secondary prevention programs by 2022 through increased referrals, enrollment, and participation. Many people within AACVPR, such as Karen Louie, Anna Mola, and Stephen Contayan, are intimately involved in not only the R2R program, but also Million Hearts, and are helping us drive the program forward. They have created resources and turnkey strategies to help individual programs improve their programs and prepare for the new episode payment model. Many of these resources and turnkey strategies are posted on the AACVPR website. Now I'd like to turn the presentation over to Kate Trainer, who will take you step by step through the R2R project.
Thanks, Tracy, for that great background information and foundational presentation. So this next portion of the webinar is where I like to affectionately refer to it as where the rubber hits the road. This is where you begin to think, and we hope that after this webinar you will think hard about what your particular strategy will be dependent on where you fall in relation to the bundled payments and the cardiac rehab incentive. Every program has skin in the game. This healthcare reform is here to stay, so whether you're impacted immediately with these bundles or further down the road as healthcare reform continues to change, we will all be impacted, and it really is imperative that everybody begin to think strategically now about how to best prepare and to critically look at your programs and practices to be certain if they're really serving you and, most importantly, the patients in the best way that they can. I love this slide. It's really a very straightforward and simple presentation that illustrates the absurdity of not making accommodations with a few very easy steps. So how do we prepare for these bundles? Let me just review with you exactly what the bundled payment is all about. Remember that it's a fixed amount of money that will be given to a participant hospital, and the participant hospital is the hospital that is in the bundle. That pool of money will need to cover the costs and expenses in managing a patient from the day of admission to the hospital through and including 90 days after discharge from the hospital for the populations of AMI and CABG. It's not dissimilar to your household budget, where you have a fixed amount of money from your income or your spouse's income perhaps that you need to use to cover all of your living expenses. And incidentals. So that's exactly what this is. It's a fixed budget that a participant hospital will have to work with. The most important first steps that you personally can take to prepare for this are to really think very hard about the three components of the cardiac rehab collaborative slide that Tracy just presented, which has to do with referral of patients to your program, how that happens and how quickly you hear about patients, enrollment of patients in your program, how quickly you get them started and how many of them you can retain. And lastly, adherence, getting them into the program and keeping them in the program and helping them through to complete the program. Remember again that the goal of participation with the Million Hearts Collaborative and Initiative is to increase participation in cardiac rehab to 70%. So we have a ways to go. So let's begin to talk a little bit about how you can prepare for these bundled payments. And although we don't have a lot of specifics just yet, I mean, if you remember back to the algorithm, that colorful slide that Tracy presented a bit ago, there will be 4 distinct arms of this bundled payment initiative. We don't know yet which geographic areas will fall into each of those 4 arms, but it's not too early to start thinking about and greasing the skids in your institution for these bundled payments and the implications of them. The very first step is to start to think hard about who are the important people or the stakeholders that can help you with planning for the changes. And there's really 3 very important groups that you should be thinking about. The first, of course, are your staff. The second would be the hospital administrators. The third would be the physician directors or supervising physicians or even frequent referred physicians to your programs that you want to be in contact with. So right now you want to start to think critically and strategically with those 3 distinct groups about how to prepare for patients. That means increasing referrals and accommodating those referrals and patients into your programs. Patients will need to start sooner. You'll want to keep them in the program or get them through to full completion. And this is going to require you, because of the increased volume, to really think long and hard about how you manage patients in your program and whether what you're currently doing is really nice to do versus necessary to do. And so, as Tracy mentioned, there are some strategies that I'll point you to in a short while that can help you perhaps begin to think a little bit creatively outside the box for how to manage patients in the program, and maybe even consider new program treatment models, whether that be incorporating a home-based component to your cardiac rehab program or what we refer to as hybrid model, which is a combination of the patient coming to your center or facility for cardiac rehab, but also participating at home and you tracking progress with them at home. In order to do that hybrid program, it may be something that you want to give consideration to using some of the new telehealth technologies that are available. So again, we'll provide more specifics about all of that in just a few slides. So this is where your membership is really paying off. The R2R initiative is something that the AACVPR has begun to get out ahead of very quickly. And I also, before I go any further, want to give special recognition to the AACVPR staff that's working behind the scenes, not unlike Santa's elves at this time of the year, but really working very hard and very tirelessly in the background to pull all of this together and have these resources available to you as quickly as we can get our hands on them and prepare them ourselves. So what specifically is AACVPR doing that you can look to for help in terms of preparing to dialogue with your physicians, dialogue with your hospital administrators, as well as your staff? Well, the first, of course, will be the webinars. Today is the inaugural webinar, but you can expect at least 5 or 6 more webinars monthly over the next few months that will address a number of different topics. In December, there will be the usual healthcare policy and legislative update with Karen, Louie, and Phil Port, where we hope to have a little bit more specifics about where the MSAs are that will be involved in the bundled payments and cardiac rehab incentive. Future topics of the webinars will include more specific targeted information about dialoguing with your hospital administrators and physicians, as well as specifics to work with your staff. There will also be a webinar that focuses on information for patients and how to work a little bit more strategically and think critically about program operations, patients' adherence, and perhaps lastly about data management and some perhaps registry interface. The second new initiative as part of the R2R effort is the Spotlights. Many of you, I'm sure, have already begun to receive those. Those are the monthly communications that are giving you as much up-to-date information as we have. They're one-page email updates that will give you very specific and very recent information that relates to this whole healthcare reform initiative. There's also a dedicated website on the AACVPR webpage that you should look to, and if you need to be logged in to actually be able to access some of the actual resources that are posted on that webpage. But that's an important R2R resource for you to go to get more information about some of the topics that we'll touch on today. Each edition of News and Views will have some topical article that relates to the R2R initiative. Any affiliate meetings that the AACVPR is involved with will include always in the presentation an update with the recent information and updates relative to the healthcare reform, bundled payments, and R2R initiative. This year, the Day on the Hill is scheduled for March 13th. We hope to see as many of you there as possible. But as we normally do prior to the Day on the Hill, there's always an educational pre-conference. And this year's topic for the educational pre-conference prior to the Day on the Hill will focus on the R2R initiative. We will be developing presentations not unlike this webinar, but will be more specifically targeted on how to talk with your staff, your physician providers, as well as your administrators. The Healthcare Reform Committee of the AACVPR is really spearheading this effort. That committee is ably led by Tracy and has been really the group that has, put vision and ideas to work to help bring these resources to you. Once CMS or Medicare announces the involved MSAs in this bundled payment initiative, we are quickly ready to deploy a survey to our members who will be impacted by these bundled payments. So if you end up in one of the MSAs with the bundled payment or cardiac rehab incentive payment attached to it, you will expect and should expect to receive a membership survey that will query you specifically about what information you need and how we can be of any more help around preparing you for the July 1st implementation. Finally, AACVPR and the R2R initiative group will be reaching out to all AACVPR affiliates in the involved MSA so that we can work hand in glove with your affiliates to deliver information and content and perhaps some educational initiatives within your regions to help prepare you even further for this initiative. So together we're working hard to bring the latest information as quickly as we can to you as quickly as possible. The important thing to know is that the AACVPR is really out ahead of many other groups when it comes to this healthcare reform and bundle payment initiative. So in suggesting that you begin dialogue with your hospital physicians and administrators, it's very likely that you may have more current information than even they do. So don't be afraid to speak to them and let them know exactly and share with them the information that you glean from all of these educational resources from the AACVPR, because you too can help educate them around what's coming and what this is all about. The next aspect of the presentation, I'd like to focus on each of the 4 arms of the algorithm and discuss with you specific strategies and ideas to begin to think about if this is the case scenario that you fall into, this is how you can best prepare for that particular situation. Each strategy in each scenario will have unique strategies and ways of messaging out to your physician groups as well as your hospital administrators. So first we're going to focus on what I refer to as the blue arm, which are the group of MSAs. And again, remember that these metropolitan statistical areas are actually quite large. They're inclusive of multiple counties throughout the regions, so they can literally account for hundreds of hospitals. In this blue arm, 45 MSAs will be included in both the episode payment model, so both will be in the bundle for the AMI and CABG patients, and they will receive the cardiac rehab incentive. Before I go on to the next slide, I do want to let you know that across the country there's approximately 398 MSAs. Only 294 of those MSAs are going to be considered for any of these 4 arms. And again, that's roughly about, and of those 294 MSAs, 98 will be chosen for the bundled payment. So roughly 1/3 of all of the MSAs across the country, which is approximately, again, 700 plus hospitals, will be involved in this episodic payment model. The first group to focus on, if you fall into this particular arm where you're both participating in the bundle and receiving the incentive for cardiac rehab and talking with your staff, is to let them know that you are really in the spotlight. This is going to be a real highlight and focus for your institution. You can expect that because there's a direct financial incentive for getting patients into cardiac rehab, you will need to be prepared to accommodate more referrals. And once you have those referrals, you're going to want to reduce what we have up here as short for the door to program time, which is the D to P. So you want to receive more referrals quickly and be prepared to enroll those patients a lot sooner. Part of the thought that you might give to getting more referrals in place, if it isn't already something that is available to you, is an automatic referral process for patients that are admitted with AMI and or CABG. That the quicker you can hear about those patients and get those referrals, the better off you will be. You will then want to talk to your staff a little bit about the fact that it will be very important to be creative and to think innovatively about how to be efficient and manage this larger volume of patients in the program. And you can point them to the AACVPR R2R webpage for some of the strategies that we've alluded to a little bit to help begin your creative juices. Some of these things may not be new information, some of these strategies may not be new information, and you, in fact, may have already innovated and are using some key strategies that you might want to let us know about. So if you have any ideas, we'd appreciate the heads up and have you share some of your best practices with us so that we, in turn, might be able to share those with your colleagues across the country. Those best practice examples are going to be useful to everybody. And so this is the time that we all row in the same direction and work together to help each other out. It will be important to highlight for your staff, obviously, the health benefits of cardiac rehab, and Tracy did a nice job of outlining what those are, and those aren't going to be new information to you, but a good reminder to the staff that the more patients that we can get to avail themselves of cardiac rehab, the more patients will attain and achieve and realize those specific benefits. If you are a tertiary care hospital that tends to treat the patients, whether they come in for their AMI and PCI and or their coronary artery bypass surgery, but the patients don't stay with you for cardiac rehab and in fact are referred back to community hospitals, this is a good time for you and your staff to start to talk about how to work more effectively with those community hospitals so that you can communicate quickly with them as to who these patients are, and in turn they can enroll those patients a lot more quickly. So again, remember for everybody involved that cardiac rehab benefits are multiple and very beneficial. There's a 25% reduction in all-cause mortality for patients that participate in cardiac rehab. And that mortality reduction continues for up to 5 years post-participation. There's a reduction in symptoms for patients, and there's improved adherence with preventive medications, and exercise performance improves. All very good reasons to get patients involved in the program. So on this slide, I've circled for you the exact strategies that I've referred to and that Tracy referred to that are what we call these turnkey strategies or creative ideas that you can look to help you think a little bit more about what might work in your particular setting. If you click, you have to first of all be logged into the AACVPR website to avail yourselves of these resources. If you click on these blue links that are circled, it will take you to the document with a lot more specific information about each particular topic. If you're on the webinar today and you're not a member of AACVPR, I hope that you'll give strong consideration to becoming a member. We're happy to bring this general information to you, but to get the very specific information and full benefit of the AACVPR resources, your membership would be a very worthwhile investment, particularly at a time of change such as this. For those of you in this blue arm, again, in the bundle and receiving the cardiac rehab incentive payment, you'll want to talk to your physician. And the most important lead in talking with these physicians is that there's a direct financial incentive to enrolling patients in cardiac rehab. That in addition to the bundled payment that your facility will receive, you will receive additional monies if the patient enrolls in cardiac rehab. So that speaks a language that everybody understands. And again, you want to highlight the mortality benefit for the patients, that not only is there good financial reason to bring them in, but there's actually good value for patients here, and that is a 58% relative risk reduction in mortality at 1 year and continuing again to 34% at 5 years. And the longer that a patient stays in the program, the better off they'll be, and that's what we call dose dependent. The more number of visits and touches that you have with that patient, and be in a position about your challenges with getting patients referred to your program. Automatic referral, as I suggested, may be one way of doing it, but you certainly know what your pitfalls are at this point and what some of your barriers are. This is the time to be talking to your physicians and saying you could use some help in that regard to work around barriers. Remember to use language also that they understand. Cardiac rehab is probably one of the first and most cost-effective disease management models. It treats the whole patient and encompasses every cardiac risk factor that they have. You are the physician's partner in helping patients with medication compliance, lifestyle modification of their cardiovascular risk, their education, as well as improving their satisfaction with care at your institution. The CGCAPS acronym that you see here is the required patient satisfaction survey for outpatient practices by CMS. The acronym stands for Clinician and Group Consumer Assessment of Healthcare Provider and Systems. In other words, it's a direct ask of your patients about how satisfied they are with the care they received in your institution. And if they come into programs like cardiac rehab and derive these kinds of benefits, they're going to be very happy customers, and they're going to answer that survey in that way. Hospitals are very tuned into their scores on the CGCAPS survey. Remember to dialogue with the physicians about the reduction in rehospitalization, because if patients get rehospitalized, it's costly for institutions, and with a fixed payment, we certainly want to keep patients out of the hospital. You can help physicians by surveying and watching your patients' clinical outcomes and how well they're improving and making progress. You can help them get to the physician services that they need more quickly. And remember to remind them that despite all of these benefits, that cardiac rehab is grossly underutilized, and this is really an opportunity for you and your institution to change that and turn that around. This is the strategy to speak with the hospital administrators, and again, it may not be something that all of you are comfortable with or that you've done, but this is an opportunity for you to step outside that a little bit and try to, begin to talk with some of your hospital administrators about why you need to be a player and why you are involved in this bundled payment initiative. To those of you on the phone that may be hospital administrators, I'm going to apologize right now, but the first message to these hospital administrators, you are going to bring additional money into the hospital beyond the fixed bundled payment. It would be important, of course, to include for them in your conversations with them all of the benefits of cardiac rehab that we've already just had suggested you discuss with your staff and the physicians around mortality benefits, fewer emergency room visits, less rehospitalization. And really, if you know, and you should know, your own program's outcomes, this is the right time to bring that to your hospital administrators and let them know what your local experience is and what your local outcomes are, so that they can see that you're already doing great things and that you can do more great things if you have more patients referred to you and getting matriculated into your program. It's a great time for you to dialogue with them about the barriers as well, and let them know where you see some of the challenges will be and what help you'll need from them to navigate those challenges and to work around those barriers. Cardiac rehab is a solution not only financially, but to help with keeping patients on the correct medications, reducing all of the risk factors that could lead to further issues in terms of their cardiovascular disease, and will decrease ultimately their health expenditures down the road. Hospital administrators understand the CGCAP scores and look to those as well to keep patients and to make certain that they're delivering services that are keeping patients satisfied. So you can let them know that patients that come through cardiac rehab will have that pleasure and that happy outcome reflected in their CGCAP scores. And again, hospitalization costs for patients for cardiac admissions after a follow-up period were essential, on an average, $900 less for those that participated in cardiac rehab programs and those versus those who did not. We're going to shift now into the orange arm of the bundled payment algorithm, and this is going to be the group of MSAs and all of the hospitals within those 53 MSAs that end up in the bundled payment model but do not receive the cardiac rehab incentive. This is going to be a very challenging group for you if this is where you end up in the arm of this algorithm. You absolutely, and I'm going to repeat, absolutely do not want to be cut out of the bundle. Remember, the hospital will receive a fixed payment. They will need to pay for all services and all care for that patient out of that fixed premium. So you want to be certain that you help your staff, your physicians, and your hospital administrators understand why cardiac rehab needs to be kept in as a service and not delayed until 90 days after hospital discharge. That may be a solution that somebody suggests. But remember, the sooner you can get patients started, the more quickly they can derive this benefit, and the more likely it is that you can keep them out of emergency rooms and prevent rehospitalization. So you have your work cut out for you in this model, but I trust that each one of you, as we go through these slides and talking points, will be able to make a very, very good arguments and justifications for as to why patients should remain in cardiac rehab and should remain as part of the care of these patients, despite the fact there's no built-in additional financial incentive. The suggestion is that you obviously look at all aspects of your referral, enrollment, and adherence and discuss that with your staff, that your results can really shape the future of cardiac rehab as healthcare reform continues to evolve. That you want to show that patients that, although there wasn't a built-in financial incentive, that patients still benefited, still got into your program and did very well. And CMS will be looking to see how many patients participate in this arm and what the outcomes are for patients that do versus those patients that don't get referred into and don't matriculate in cardiac rehab programs. Please stay informed and encourage your staff to pay attention to the spotlights, the webinars, and the resources on the website to stay updated and thoughtful about creative strategies and new information that comes forward. You'll want to work, again, hand in glove with the community hospitals if you're a referral hospital typically, so that you can efficiently get patients into programs and get them on the work of secondary prevention as quickly as possible. So again, this is really going to be a very challenging arm of the bundled payment algorithm to be in, but I absolutely trust that you can make a thoughtful justification as to why you want to be included. So in discussing with the physicians, the most important lead-in that I would suggest that you have is that you talk about the benefits of cardiac rehab participation. This is why patients should be in the program. And you start with the benefits of cardiac rehab. And again, your own program outcomes will be some of the most convincing evidence that you can offer. So I would suggest that you make certain that they understand what your outcomes are and how well your patients, and their patients in particular, are doing. Be very familiar with mortality benefit to cardiac rehab participation, the reduction in readmissions, and all of that information. This webinar will be posted on the website. You can refer back to those slides for those particular numbers and even the studies, and offer those kinds of resources to your physicians so that they can look at those studies as well. An automatic referral process is a must if you want to have timely referral and enrollment in your program. So I would talk with your physicians again about trying to work together to have that happen. You want to document any and all circumstances where you've helped a patient avoid an emergency room visit or rehospitalization. That dollars saved, and you want to have the physicians understand real-life examples of how that's happened and the difference that you made in that happening. The other important aspect of this is to not be afraid to suggest that patients communicate back to their physicians how happy and satisfied they are with having been a part of this cardiac rehab program of yours. That having them do your shameless plug is not, it's absolutely the right thing to do. And that physicians like to hear that their patients are happy. And so make certain that you ask patients if they thank you and say that they can never repay you for all that you've done for them. You can say, well, certainly there is one small thing that you can do, and encourage them to not only tell their physicians how happy they were with their participation, but to also maybe write a letter to your hospital administrators, and we'll get to that a little bit on the next slide. So be proactive. This is the most important scenario for you to get out there and start talking with your physicians and your hospital administrators about making certain that you're still going to get patients into your program. And I think the most important take-home message is the last line on this slide, which is that if we are not the solution, there will be a way that somebody will find to make certain that patients get help in this 90-day post-discharge period. So we have to be absolutely convincing that we're the solution here and not looking for another proxy to cardiac rehab. In speaking with your hospital administrators, first and foremost, connect with them and don't be afraid to speak with them. And when I say talk the talk, I mean let them know, again, what the benefits are to participation in cardiac rehab. They understand readmission rates, they understand rehospitalization costs, and they understand how important it is that patients remain compliant with medications and post-hospital discharge care. Those are all the advantages that you offer when patients come into cardiac rehab. Be very conversant about financial advantages. They will understand it when you translate it into dollars and cents. So remind them about the lower cost of managing patients and the lower readmission costs for patients that participate in cardiac rehab versus those that do not. They need to understand the dose-dependent concept, which means the more visits patients have in cardiac rehab, the better off they do and the better their outcomes. Share your plans with your hospital administrators about how you're going to build in efficiencies to accommodate more patients, because you want more patients to realize benefits. Let them know what you're already thinking about doing to have that happen so that you can accommodate them and move them through quickly. And again, discuss cardiac rehab as the solution, again, highlighting the cost savings and the patient satisfaction. Let's talk a little bit now about the yellow arm of the study, which is really a kind of a nice soft landing spot for you if this is an MSA that you end up in. So this is going to be the group of MSAs that are not in the bundled payment. Will continue to get fee-for-service payments for patients that participate in cardiac rehab, but there will be the benefit of the cardiac rehab incentive additional payments here. This is the best case scenario. So not only will you get paid for your customary payment for cardiac rehab, but you'll have the benefit of the additional payment. And remind your staff that that means $25 for every session between session 1 through session 11, and an additional $175 for sessions 12 through 36. You have nothing to lose in this scenario and everything to gain. But you've got to work hard in what I call make hay while the sun shines. So remember, that additional incentive is only going to be available to you for 90 days. Patients can stay in the program longer than 90 days, but your incentive payments will stop at 90 days. So you want to get to work quickly on referrals, enrollment, and adherence in this scenario. Talk to the physicians now. Get talking about financial incentives, that you will receive extra money for getting these patients into your program. You'll be paid for cardiac rehab as you do now, but there'll be even more payment because of this cardiac rehab incentive that's available for 90 days after discharge. So again, talking up the benefits, use this as an opportunity to raise the profile of your program. You're going to be able to increase the bottom line of the institution. So make use of the resources on the website to help you make compelling arguments for making your enrollment processes a little bit smoother. Track your outcomes, and really most importantly, I would suggest tracking the additional dollars that you earn through this incentive so that you can report back exactly how much additional money you brought into the institution. So this is your chance to talk to the hospital administrators. Again, remember the bean counters about you're going to be helping them increase their financial bottom line. Be certain that they understand the incentive, because this is probably one aspect of this whole reform that they're going to know the least amount about. So just explain to them what the additional payment is and how that breaks out over the course of the 2 tiers, the sessions 1 through 11 at $25 and the sessions 12 through 36 at $175 additional. And also let them know that this financial incentive can be used to benefit the patients. You can use it to offset the cost of transportation, whether that be parking perhaps, or transportation costs on public transportation, whether that's your subway system or wherever it might be. It's not clear, and I don't believe you can use this financial incentive to offset co-payment. So it would be for other ways of keeping patients adhering to your programs and attending your programs. Showcase your outcomes, and again, showcase the bottom line financial extra dollars that you bring into the hospital. So the last group, the purple group, is for everybody who doesn't end up in a bundle, who doesn't receive the cardiac rehab incentive payment, and who was never really even eligible. So remember, there was 398 MSAs across the country, but only 294 eligible. So that left out, there's more than just 151 MSAs that will end up in this situation. There's probably more like 270, give or take, that will end up. So we're talking about lots of hospitals that will be pretty much continuing to function in the way that we know things at this point, which is the fee-for-service world. So in this arm, I don't want you to think about this as business as usual, because you really have the luxury of time, and that's what you want to say to your staff. You don't want them to say, oh, we don't have to worry about those bundles or that cardiac rehab incentive, shucks, we missed out on it. You want to say instead, hey, look, we have been given the benefit of a little bit more time to prepare. It's inevitable. It's coming. So let's just use this and be smart and think ahead and be anticipatory in getting ready for this, because it is going to come our way. And my old high school basketball coach used to say that the best defense is a good offense. So this is where you want to start thinking now about program efficiencies and increasing all of the enrollment and referral rates that we've talked about a little bit. The future care, the future of healthcare, is maintaining high quality while being cost effective. And so this is the opportunity for you to do that and to think through. So what I would suggest is that you actually approach this as if you were in the bundle and say to your staff, what if we had been in the bundle? How could we look at these 3 aspects of managing our program a little bit more effectively? In discussing with physicians, you might also use that same kind of what if scenario with your discussions with them, that we dodged the bullet, but it's going to come a little bit later. And so what if we were to end up in a bundle, or what are we going to do when healthcare reform is at our doorstep? And begin to talk to them again about all of the same strategies that we've discussed so far around referral, enrollment, and adherence. And again, remembering that the benefits of cardiac rehab are going to be your biggest selling point. You have the luxury of time, so work together with your physician colleagues to prepare for that. So for your hospital administrators, the message is it won't be business as usual for long, and you really want to work with them and physicians to be prepared so that when it does happen, you will have a well-thought-out strategy that you can implement quickly. This is a real good time for you to really advocate with your patients that they write letters to the hospital administrators and physician directors of your programs, or referring physicians, or hospital directors and presidents, chiefs of cardiology, and express in their own words to those groups how important the role of cardiac rehab has been in their recovery. So those letters actually go a long way in that the physicians and the hospital administrators pay attention to those kinds of letters from patients. Those are the customers that they want to keep happy. So I hope that we've given you a lot of food for thought. I think what I'd suggest at this point is, since we don't know yet which arm any of us are in, when that information comes forward within the next month or so, that you revisit the 4 arms and re-review for yourself the strategies for each of those depending on where you end up. And we'll continue to update the R2R website and continually add new resources as it becomes available. So to close our presentation today, and because I am from Boston after all, I wanted to channel my Boston roots and sort of have you thinking a little bit along the lines of the quote that JFK used many years ago in his address when he was inaugurated as the President of the United States. And I'm going to change it up a little bit and suggest that think not what cardiac rehab can do for you, but what we all can do together for cardiac rehab by embracing the change and preparing for the challenges ahead. Thank you all for listening in this afternoon, and I hope that you will continue to look to the AACVPR for help in preparing you for the healthcare reform that's coming.